Good morning. It's okay. Hi, everyone. Good morning, good morning, good morning. Thank you for being here this morning. This is my last day here, my last lecture. Um, let's talk about meningitis. If you remember, I think in the on Tuesday we talked about the anatomy of the brain, and we talked about meninges, which is a wrap, something that wraps around the brain and all the way down the spine. That's meninges. And we have three layers in meninges. You have um, the top layer is dura mater, if you remember. The middle layer is arachnoid matter, and the one that's stuck to the brain is pia matter. Dura is stuck to the skull, pia matter is stuck to the brain, and uh, arachnoid is kind of loosely in between. The meningitis usually happens here because you have fluid in here, you have vessels in here, you have more room in here, and the inflammation and infection can happen here. So meningitis, the word meningitis has two uh, components. One is meninges that we just talked about, and then itis, which means inflammation. So you have inflammation in the meninges. Uh, as I said, from the three layers of meninges, mostly the leptomeninges is involved, which is pia mater and arachnoid matter. Encephalitis means inflammation of the brain, and sometimes you have inflammation in the meninges and in the brain at the same time. That's called meningoencephalitis. We talked about uh, uh, brain vasculature as having really unique qualities compared to the rest of the body. One of the qualities that uh, uh, brain vasculature had was autoregulation, if you remember. The brain vessels can um, constrict and dilate uh, per demand. If the blood pressure is too high, the vessels can constrict to avoid damage to the brain. And when the blood flow is not enough, they can dilate to drag more blood into the brain. That's called autoregulation. That's only unique to the cerebral arteries. But cerebral arteries have another quality that is just unbelievably protective of the brain, and that's something called blood-brain barrier. So the rest of the vessels in the body, they have endothelium, but brain vessels have something we call blood-brain barrier. So it's a combination. It's a structured composed of endothelial cells, pericytes, capillary basement membranes, and astrocytes. So this thick layer is very selective about what can go through the vessels and enter the brain. There's like a barrier, there's a border. And this prevents toxins or other harmful material to go from the blood vessels in the brain and enter the brain. It's a very protective layer that controls what goes inside the brain. That's great. But at the same time, it has some uh, downsides, right? Because sometimes it limits the choices that we have in terms of medication to treat the infection because not every antibiotics or every medication can cross the blood-brain barrier. The same restrictions sometimes apply to the medications. But when blood-brain barrier is compromised, bad things can happen because every garbage from the blood vessels can get into, not that we have a lot of garbage in the blood vessels, but I mean toxins and other things. When blood-brain barrier is compromised, then the toxins and inflammatory markers and other things can go through the vessels and enter the brain, and bad things happen. Just look at President Trump. So the garbage gets to his brain, and then he acts on it. That's a man whose blood-brain barrier has been compromised. Sorry, don't want to insult anybody's politics, but So what happens? What triggers the inflammation? The inflammation can happen from autoimmune diseases. Autoimmune diseases are known for inflammatory triggers. They are all inflammatory processes that can inflame the meninges, infectious causes, viruses, bacteria, fungi, and something that we think about less is medications. Penicillins can cause inflammation in the brain. Um, NSAIDs, Motrin, can cause inflammation in the brain. So when you prescribe that unnecessary antibiotics for viral URI, think what could this antibiotic cause? It can cause meningitis. Yeah, it's rare, but it's there. And of course, toxins can do the same thing. How the how does a bug, a bacteria, a virus enters the brain? We said blood-brain barrier is a really effective barrier. So if they can't get into the brain through the blood-brain barrier, how else do they get into the brain? One way they do it is by direct access. So if you have a skull fracture, or if there is a defect in the skull, then they can come from the skin, they can enter from the scalp directly into the brain and cause meningitis or encephalitis or meningoencephalitis. Um, uh, many years ago, when Haemophilus influenza was around, a lot of kids had really invasive ear infections. And then when you have ear infection inside the ear, sometimes the infection eroded the bone and then entered the brain from there. We had a lot of meningitis from Haemophilus B, um, Haemophilus influenza B in the past. Luckily, with the vaccination, we don't see Haemophilus B, Haemophilus influenza anymore. So that type of meningitis is almost extinct. Now, with an anti-vaxxers being at the helm of healthcare in the United States, brace for a lot of uh, the extinct bacteria to come back. We already see measles is coming back. Most likely chickenpox, mumps are coming back. Most likely Haemophilus influenza is going to come back. And then you're going to see more and more meningitis. Mumps and chickenpox were common causes of viral meningitis in the old days. And the fact that we don't see them anymore is because of vaccination. They're going to make a comeback. People who have sinusitis, who have invasive sinusitis, chronic sinusitis, again, the infection can erode the bone and the bacteria can enter the brain. So one way for the uh, bacteria to get to the brain is through direct access. Other option is hematogenesis spread. So the blood-brain barrier, as we said, is very effective, but there are still some ways that the bacteria can cross the blood-brain barrier. One way is we have certain proteins, certain receptors in the brain that they have a specific functions, but they are the weak links. Sometimes they allow the bacteria to go through them and enter the brain. They're called Casper uh, receptors. That's like a spy name, but they are really spies that allow bacteria to enter the brain. Sometimes some bacteria that have affinity for that specific protein, they can use them to enter the cell. Um, Very commonly, you have damaged tissue. Let's say you have a stroke that has damaged the tissue. You have a hemorrhage that has damaged the certain part of the brain, including the vessels, and that's how the bacteria can enter the brain. There's also one part of the brain that's very vulnerable. It's called the choroid plexus. Choroid plexus' job is to produce CSF and absorb CSF. Because there's a lot of traffic, fluid going in, fluid uh, coming back, that's probably the weak link in the blood-brain barrier, and sometimes that uh, the bacteria can enter to the brain from that area. But most of the time, you need some damaged tissue in the brain, damaged blood vessels, and that's where the blood-brain barrier is broken and compromised, and bacteria can enter from there. So when the body or when the brain identifies a foreign invader, which is a bacteria or virus or fungus, immediately it recruits white blood cells. White blood cells come to um, the, the, the area. They produce a lot of inflammatory markers like cytokines, and cytokines recruit other protective cells and more white blood cells. So it's a cascade of inflammatory markers, inflammatory cells, inflammatory markers, inflammatory cells, and the inflammation really picks up. Uh, as we said, different types of bugs can cause meningitis. You have um, bacteria, viruses, fungi, even parasites do it. For bacteria, um, bacterial meningitis depends on the age. Because people have different immune responses, different immune system at different ages, then the bacteria that infect them for meningitis is also different. In newborn, you usually have strep group B, E. coli, or listeria. These are the most common causes of bacterial meningitis. So the choice of antibiotic that you make has to be the ones that affect these bacteria. In children and teenagers, Neisseria meningitis and strep pneumonia. In adults and elderly, strep pneumonia and listeria. These are so there are three different age groups have different bacteria meningitis. And I just threw Lyme disease there because something that you might not think of, but especially in endemic areas such as New England area, you will see a lot of meningitis due to Lyme disease. Viruses are more common. Enteroviruses, herpes, HIV, less common to be more common. Mumps and varicella zoster. These are common causes of viral meningitis, which are generally less severe and more self-limiting, luckily. The different fungi that can cause meningitis, Cryptococcus and Coccidioides, um, tuberculous meningitis, the Mycobacterium. I used to work many moons ago. I used to work with Doctors Without Borders, and at some point we were working with Afghan refugees where tuberculosis was endemic among them. And there I saw every possible type of tuberculosis, not only pulmonary tuberculosis, but tuberculous osteomyelitis, tuberculous peritonitis, and of course, tuberculous meningitis, which is extremely hard to treat. And then in endemic areas where malaria is endemic, you can have uh, malaria malaria meningitis from falciparum. All right, let's talk about clinical features. Almost 95% of people have fever, meningismus, and altered mental status. So the triad of, sorry, so people, people have fever, headache, neck rigidity, neck pain. The headache, neck rigidity, neck pain is called the meningismus triad. Um, Most people have fever, and a lot of people have some variation of altered mental status. So this is going to be very challenging because, especially in children, you're going to be seeing whether you work in an emergency room or become a pediatrician or a family physician or general practitioner, you're going to be seeing a lot of kids with fever. And kids, when they have fever, they usually more subdued. They have less activity, less appetite. When the fever is high, they might look lethargic. So you're going to be seeing thousands of those kids, and you have to be able to identify the one sick kid that is has meningitis among those patients. So it's like looking for a needle in the haystack. And that's going to be challenging because you're not going to do blood work on all of them. You're not going to do lumbar puncture on a lot of them. So how do you do this? The more patients you see, the more you will rely on your clinical judgment. That when you see a child, you can tell by the way the child looks that this is more serious than just a viral URI or regular infant fever. You have to be able to look at the child and say this child does not look well. So when we talk to when we teach our residents in the emergency department, we always ask them to document how the child looks. Like I personally write the child is eating chips, is talking, he's looking um, at mom's phone or running around the ED, looks well. These are the clues that I'm documenting to mention that this child doesn't have anything serious. Um, but if you see the child is refusing feeding or it looks really, really tired or is refusing eating or drinking anything, that is a bad sign that the child might have more serious illness than just a URI. So infants are annoying in general, but during if they have meningitis, they could be even more annoying. What I mean by that is they become very irritable and unconsolable. So you have a child who nothing will stop them from crying. And when you see one, you know it. There is nothing that you can do or the mom can do to stop them from crying. That's called the inconsolability. And that's a bad sign. That means something serious is happening. They can also go to the other extreme and they can be very, very lethargic. They could be very sleepy. It would be very, very hard to wake them up because infants, physical exam or the physical tests that we have on them, for infants, those things don't work. So you have to just use your clinical judgment based on how they're acting. And if they're unconsolable or they're too lethargic and less responsive, that should be your clue that something is cooking. It's very important to obtain a really, really good history. Is this patient immunocompromised? Is there anything that could um, uh, uh, weaken the immune system for this person and expose them to meningitis? A good history about the immune situation. Is this child vaccinated or not? Any history of CNS disease? People who, as I said, if there is a brain damage that makes them more prone to damage to the blood-brain barrier and more prone to bacteria to get into the brain. Is there any evidence of stroke or any focal infection, any mass lesion? If you ask for history of sinusitis, history of frequent ear infections, and that those could be your clue to possible meningitis. People who have new-onset seizure. Remember, when the tissue is infected, tissue is damaged, it can create an excitable or irritable focus that could start seizure. When you look at the back of the eye, when you look at the retina, you get the optic disc. If the optic disc is edematous, what we call papilledema, that's usually an indication that there's inflammation and increased ICP in the brain. Of course, level of consciousness uh, is a good clue. If you're lucky, you will find focal neurological deficits, usually in meningitis or encephalitis. Neurological deficits are rare, but if they are there, that could be your clue that there could be infection. And rash is a good clue, especially in meningococcal meningitis. You kids have a rash that's called petechia. When you see that, that's a good help that can help you identify meningitis. We have two tests, Brudzinski and Koenig test. The first one is um, when, because as I said, dura goes from brain and all the way down to spine. When dura is inflamed, stretching it will be difficult and stretching it will be painful. So if someone is sleeping flat, you raise their neck. That's why you're stretching the meninges, you're stretching the dura. They have to fold their knees to prevent the stretching of the dura. So that's a test. You raise the neck and you immediately see they are folding their knees because they cannot stay flat and allow the dura to stretch. That's one test. The other test is they're when the patient is laying on their back, fold the knee 90%, and as when you extend the knee, uh, they feel pain and they feel the stretching of um, the entire back. That's another clue that every time you stretch the dura or meninges, it it's uncomfortable for the patient. But unfortunately, these are not a very sensitive test. If they are there, they're very good clues, but not if they are not there, doesn't mean the patient doesn't have meningitis. So you need to be very aggressive to treat meningitis. This is not the time to wait and see and let me see, let me do this blood test, let me do this other thing. The moment you suspect meningitis, you have to act on it. You have to be very, very aggressive and act on your clinical judgment, on your clues. Immediately get to work, put IV, put the patient on oxygen if needed, cardiac monitor, do your ABCDs, and then you can do your diagnostic workup. The only diagnostic workup that you can do is maybe you send a CPC if you have leukocytosis. Leukocytosis means there's an inflammation, there's an infection. Um, doesn't, of course, mean patient has meningitis, but if you have a suspicion of meningitis, a decent leukocytosis could confirm your suspicion. You can send blood cultures. Blood cultures are not positive in all cases of meningitis, but if they're positive, they can guide your treatment. They can tell you what bug you're dealing with and what antibiotics to choose. But your best diagnostic test is a lumbar puncture. That's way that because the CSF goes around the meninges, is it in touch with meninges, and if the meninges is infected, then CSF will be infected. So by accessing the CSF, you can do the test. You can send gram stain, stain the CSF and look for the bacteria or the virus. You can culture, viral culture, CSF called bacterial culture, and you can look for the WBCs in the CSF, and it can really guide you to diagnosis of meningitis. Sometimes in the past, we used to do a lot of CT scans before we did lumbar puncture because they said if there's a space occupying lesion, if the ICP is high and you do lumbar puncture, you can cause herniation. That has been kind of debunked. It's a myth. If if you're suspecting space occupying lesion or brain mass, it's still justified to get a CAT scan. But if there is no indication, if there's, the patient doesn't have history of cancer, they don't have history of metastasis to the brain, they have normal neurological function, there's no reason to get a CAT scan before the LP. So the moment you suspect meningitis, you go for the lumbar puncture. So CSF is usually a very sterile fluid. It's very clear. It really looks like water, um, clear and fluid. Usually, you have if you look at CSF under the microscope, in every high power field, you should not see more than 5 WBCs. So WBCs are rare in the in CSF. If you look in every high power field, there shouldn't be more than 5 WBCs, and there should be zero uh, uh, polymorphonuclear cells. If there are any WBCs, they should be either lymphocytes or monocytes, no PMNs. If you see even one PMN, that's an indicator of an infection. The protein level should be 15 to 50 milligram per deciliter. Glucose should be 45 to 100. And then the pressure in the CSF is usually around 15 milligram. When 50 millimeter mercury. When we do the lumbar puncture, we are able to measure the pressure by which the CSF comes out. There's usually a, a, a pressure meter that is attached, and the CSF goes up, and the level that it stops shows you the pressure. When you see the pressure is high, more than 15, that means there is an infection in CSF, because there's more inflammatory cells, more inflammatory markers, and those increase the pressure in the CSF. The way we do lumbar puncture is, just imagine your spine goes usually down to L1, L2. Spine ends there. So you don't want to do the lumbar puncture when there's a chance that you might poke the the spine. Usually we go between L2, L3, or preferably even L3, L4, and there's no spine, and you only have quadra equina, which is what I think the translated into horse tail, which are the nerve endings that are coming down, but there's no spine there. Positioning is everything. You have to position the patient in a shape that there's opening between the vertebrae. Um, put your needle in there, draw some fluid, measure the pressure, draw some fluid that will you send for gram stain for CSF culture to measure protein and glucose, um, and then that's your diagnostic test. As I said, the normal pressure is somewhere between 17 to 18, roughly 15. The fluid is usually clear. Protein is 23 to 38. Glucose, glucose usually is two-thirds of whatever glucose is in the serum. So you'll have a BMP or CMP that you measure the blood glucose, and then your glucose in the CSF should be two-thirds of that. Gram stain has to be negative, and as I said, you shouldn't have more than 5 white blood cells in high power field. If you have bacterial infection, bacterial infected CSF, the pressure is usually high, could be more than 30. The fluid looks turbid, looks cloudy. Um, Protein goes up, glucose comes down. Just think about it. You have a lot of inflammatory cells in the CSF, and they're going to consume the glucose. So glucose is going to be down, and then you're going to have a lot of cell degradation, cell breakout in there. So protein is going to go up. So in an infected CSF, protein is usually up, glucose is usually down. And you're going to have neutrophils in CSF. Normally, you're not allowed to have any neutrophils in CSF. The moment you see neutrophils, that's your meningitis diagnosis. CSF in viral meningitis is almost near normal, because the fluid is going to look clear. The pressure usually is not that high, but when you see when you do the white blood cell count, you'll see a lot of lymphocytes. So that could be your clue, but it could really look like a normal CSF. The As I said, when you have meningitis, you have to be aggressive. You have to, at the moment it's in your differential diagnosis, the moment you think that I cannot really safely rule out meningitis clinically, you have to be aggressive and give your antibiotics. You cannot wait until the LP results come back. You cannot wait until your labs come back. Give the antibiotics. Um, and because you don't have your culture yet, it's called empiric antibiotic therapy, that you go by most likely um, infection agent. Again, that's because different age groups have different types of infections. Then for antibiotics will be also the same. Different ages will have different antibiotics. You don't have to memorize this. You can always look it up. And probably by the time you get to your clinical rotations or clinical um, work, these might change because all the time we develop bacterial resistance. We use certain antibiotics like candies and develop resistance. They are not going to work, or we have newer antibiotics. Just remember that your empiric antibiotic therapy has to be directed at that age group and the most likely cause of infection in that specific age group. Steroids, do steroids have a role in meningitis? Because every time you have an inflammation, you talk about inflammation, you immediately think about what if I give them some anti-inflammatory medications? Dexamethasone or other steroids are anti-inflammatory medications. It has been shown that dexamethasone, if someone has pneumococcal meningitis, dexamethasone can decrease mortality, neurological complications, and hearing loss. The old days, kids who had Haemophilus influenza B infections, they were the risk of hearing loss was very high, and dexamethasone was very helpful in reducing that risk. Since we don't have that anymore, we don't generally give dexamethasone unless the patient has pneumococcal meningitis. It really doesn't, it hasn't shown any benefit in any other types of meningitis. So think of dexamethasone if you think pneumococcal meningitis is the causative agent for the meningitis. So the big no-nos here is do not wait for uh, lumbar puncture to give the antibiotic. Do not wait for lumbar puncture results to give antibiotics. Do not wait for labs to give antibiotics. Um, the it takes the antibiotics because of the blood-brain barrier. It takes the antibiotics about 6 to 8 hours minimum for the antibiotic get from the blood into the brain. So you have plenty of time. It's not like if you give the antibiotic, then it's going to affect, clear up your CSF and it's going to mess up your diagnosis. It's going to take about 6 to 8 hours at best for the antibiotic to go from the blood into the brain. So you have plenty of time and you don't want to waste any time. You want the antibiotic to get to the brain as soon as possible. So you still have a lot of time to do lumbar puncture. You still have a lot of time to do your labs. Give the antibiotic early. So by the time you have your labs and your lumbar puncture, at least the antibiotic has kicked in and you have something on board. Don't delay antibiotics for LP. Don't delay antibiotics for labs. And don't waste time on CAT scan if there's no focal neurological deficit or if there's no history of any brain mass or any space occupying lesion in the brain. Be aggressive. So viral meningitis is very, very, very common. And luckily, most cases of viral meningitis are uh, self-limiting. They get better by themselves. Um, Mumps, varicella, herpes. These are the types of viral meningitis. Enteroviruses can cause viral meningitis. Uh, it's really hard, as I said, the lumbar, we do the lumbar puncture and there might be some clues, but it might not be very helpful. These are the different viruses that can cause meningitis. Pretty much every virus can cause viral meningitis. The bird flu that is going on right now. In New York, we have had cases of flu that's caused by bird flu, and some of those patients had presented with meningitis. Right, so brain abscess is almost like meningitis or encephalitis, with this difference that you have a big area of necrosis in the brain, uh, dead tissue, and pus, purulent discharge in a pocket in part of the brain. That's called an abscess. Abscess is dead tissue plus purulent discharge plus pus. The issue is when you have an abscess, there's no blood vessels in an abscess. So how are you going to get the antibiotic into that area? If no blood vessels goes in, then how are you going to get antibiotic in there? And that's the challenge with any abscess. That's why the only way that you treat the abscess is to get the pus out. But the other issue with abscess is you not only have inflammation, not only you have infection, but now you have a mass that's pushing on the surrounding brain tissues. And that mass effect, that edema that it causes, it can cause additional symptoms and can cause additional damage. The brain abscess is rare. It can be hematogenous, but most of the time is from direct entry from the skull or some of the infections in the head and neck infections. The presentation will be the same, but again, remember we have a mass now in the brain that's pushing on the rest of the brain, causing edema, causing pressure. In this case, it's more likely when you have a brain abscess, you're more likely to have some neurological deficit. Sometimes you can have seizure and other findings. Definitely you do antibiotics. There's some conflicting evidence that maybe steroids will help because of that edema from surrounding tissue surrounding the abscess. The jury is still out on the steroids, but antibiotics are the first, not necessarily the first one. We still give antibiotics, but we know that antibiotics are not going to work for an abscess. They might treat the infection surrounding the abscess, but they are never going to get inside the abscess. So the only way to treat an abscess is to just go in and do incision and drainage. You have to go in and aspirate the pus, get the pus out, and then antibiotics will take care of the rest. Lastly, encephalitis. It's infection of the entire brain. Uh, the presentation again is similar to meningitis, but more dramatic. Especially the altered mental status is more dramatic. People are confused, lethargic, delirious, um, uh, or sometimes in coma because now the entire brain, not only the meninges, but the entire brain is infected. So the mental status changes are more dramatic. People are more likely to have seizures. They are more likely to have focal neurological deficit, and the rest of the symptoms that can come with meningitis are the same. Just like meningitis, you have all different types of etiologies that can cause encephalitis. Pretty much anything that can cause meningitis can cause encephalitis. But you also have some other reasons like metabolic encephalitis, hypertension, and some metabolic diseases can cause encephalitis, which are sometimes difficult to diagnose. Uh, in my experience, I've seen more herpes simplex uh, meningitis. The viral causes are more common, especially herpes, varicella, which is chickenpox and shingles. They can cause meningitis, measles, mumps, rubella, we talked about, and you have all different types of animal-related viruses and tick-borne encephalitis, Japanese encephalitis, rabies, and I said bird flu, West Nile, all of those can cause meningoencephalitis. Oh, that's it. All right. All right, so this was my last lecture today. Until next time, it was uh, it was my pleasure to be here. Thank you so much for having me. I started the week with evidence-based medicine. I talked about patient-oriented outcome. We talked about patient preferences and circumstances, and patients being the center of your universe, the medical universe. And I want to wrap up with the same thing um, by saying that you need to be skeptical. Everything that you learn, everything that you see, always be skeptical and think, is this going to affect my patient? Is this good for my patient, bad for my patient? Unfortunately, when you graduate, when you go out to join the workforce, you will realize that a lot of things that you're doing, a lot of policies and procedures and protocol that you follow have nothing to do with the patients. They are there to help the hospitals make more money or help the insurance company to make more money. Healthcare in the US is predominantly run by corporates. Corporates run the hospitals, corporate run the physicians group. Right now, the corporates are buying every hospital, every physician group, every clinic, and their objective is to make money. And you will see that they will do everything to do will be for them, not for the patients. You have to remember why you're doing this, why you have sacrificed the best decade of your life plus the rest of your life, not for money, right? Let's put this in perspective. You are sacrificing at the best decade of your life. You're being away from your families. You're studying. You're dealing with patients. You're dealing with urine and vomit and uh, blood all the time. Plus, the rest of your life, you still have to be working like a dog. Forgive me for saying that. Is this for money or lifestyle? How much how much is your life worth? How much the best decade of your life is worth? How much value, monetary value do you put on it? Is it worth it? Millions of dollars cannot compensate for what you're sacrificing, right? So it can be money, it cannot be lifestyle. It has to be something else. Is this for um, prestige or bragging rights for your parents? Is it worth it? No. But what you're doing is important because when you show up to work, somebody's life is going to change for the better because you showed up to work that day, right? That's what's worth it. So what you're doing is to help your patients. Everything you do, all the sacrifices that you make, you're doing it for your patients. So keep that in mind. Everything you do is for your patient. You are servicing your patients, so you have to be their advocate. So everything you learn, everything you do, that every prescription that you write, every test that you order, every um, procedure that you do, just keep in mind, is this going to impact my patient? Is this good for my patient? Always remember who is on the other side of the stethoscope and don't let the noise distract you. Okay. Good luck with the rest of your studies, and hopefully our paths will cross in the future. Thank you.